I'm delighted to have Tim with us today during this webinar. This isn't a common occurrence. Usually it's just doctors talking to you and sort of going over the clinical information, but I thought this would add a lot of value. And I bet that a lot of men and a lot of couples are probably more excited to hear from an actual patient and sort of the real experiences rather than myself. So what I'll do is I will cut to the chase. I will get through this conversation, this presentation, as quickly and as informatively as I can. And then let's get to the real stuff, the meat of the substance, which is, answering your questions, hearing from folks that you could trust in terms of what their experience has been. And Tim will kind of, hopefully we'll be able to get him on. I think we were having some audio issues, but hopefully you guys will get to hear about what I call the good, bad, and the ugly of this whole process. So let's get started. Just a little disclaimer for this talk, and it is sponsored by Coloplast, which is a company that does design penile implant and penile prosthesis. So the goal of this presentation is to learn a little bit more about erectile dysfunction. What is ED? What are the causes of ED? What are the impacts of ED? If we can understand what ED is and how it occurs, we can actually focus on how treatment works and sort of go through all the treatments. I'm going to lay out the menu for you when it comes to treatments for erectile dysfunction. In summary, there are 5 FDA-approved treatments for ED. We're not going to talk about things that are experimental, things that are sort of being sold to guys at men's clinics. That's really not the focus of this conversation. We know those are not FDA-approved and therefore perhaps not the best place to start for most men. And then we'll get to the questions, which is really the most important part of today. So you guys are all here, and I appreciate you being here. We know why we're here. This conversation is difficult. ED has a significant impact on intimacy, not just for the man, but for the couple. But beyond that, it impacts your daily life and your overall confidence. So I appreciate you being here. And I hope that you find this to be an important 30 minutes or an hour with me, and that you'll take a lot from this, and then ultimately, hopefully, we'll be able to restore intimacy, restore confidence, and get you where you want to be. First and foremost, this is not uncommon. Erectile dysfunction is a common problem, and it happens to everyone. So just know that you're not alone. Probably more than 50 million men in the US have erectile dysfunction. Believe it or not, 40% of men are experiencing some degree of erectile dysfunction by the age of 40. So that's starting pretty early. And in most cases, erectile dysfunction can be treated. And I would probably venture out to say in almost every case, erectile dysfunction can be treated. If you've got the will, there's a way. As you might experience, and a lot of guys are going to be nodding at this point, ED has many psychological impacts on your life. And this is not coming from just the one survey that's outlined here. There are many, many surveys that show the same sort of findings. More than 50% of men say that erectile dysfunction negatively impacts their day-to-day life. Almost 85% of patients say that ED causes them to have a lower confidence. Half of the patients say ED negatively impacts their relationship with their significant other, and nearly 70% of patients say that ED negatively impacts their ability to have intimacy with anyone. And things that men experience are disappointment, frustration, anger, feeling ashamed or embarrassed about the situation, and feeling insecure. I'm here to tell you this is common. It happens to everyone. And I know that a lot of partners are very understanding when this does happen. But I want you to know that this is not a you problem only. This is a very, very common problem. ED or erectile dysfunction is the consistent inability to sustain an erection that's sufficient for sexual intercourse. It may mean not getting an erection at all. It could mean that it's inconsistent. Sometimes it's great, sometimes it's not. It means that sometimes you can't maintain the erection for the duration of intercourse. So it has a variety of different meanings to men, but any inability to have confidence in your erections can be defined as erectile dysfunction. So there are some common causes of erectile dysfunction. And I'm going to disagree with this slide. The slide says it is not an inevitable part of aging. Well, it's fixable. That's why it's not inevitable. But I would argue that every man that if he lives long enough, is going to develop erectile dysfunction. There are some common physical causes of erectile dysfunction, such as diabetes, which is a really, really bad problem when it comes to ED, high blood pressure, or more commonly cardiovascular disease. Diabetes is a really bad one because it not only affects the arteries of the penis by causing plaque buildup in those arteries, but it also causes glucose deposits into the arteries as well as the nerves of the penis, sort of that double whammy effect, worsening the erectile dysfunction. Surgeries such as prostate removals, for example, robotic prostatectomies for prostate cancer, are a common cause of erectile dysfunction. Medications and substances such as tobacco, alcohol, drugs, many medications such as antidepressants, antipsychotic medicines, and even common medicines like high blood pressure medicines will cause erectile dysfunction. So this becomes a very, very big category of causes for erectile dysfunction. And certainly patients that have unfortunate injuries such as spinal cord injury or some kind of a pelvic trauma are also at risk for erectile dysfunction. So once again, 80% of the time, ED has a sort of a cause that you can point to. But I do believe, and most of us do believe, that it is inevitable if you live long enough. And I'll explain why that is in the next coming slides. In order to understand dysfunction, let's try to understand erectile function. And I apologize for the graphic image that many of you are seeing on the screen, but in pictures, are more than 1,000 words, right? So if we look at the cross section of the penis, I call it sort of the clock face. You've got the 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock, and in that cross section, you'll see sort of this almost like a face of a bee, if you will. You've got the two eyes and a mouth at the bottom. The two eyes that we're referring to are the erectile bodies. These are what I call the penile cylinders that cause erections, and the bottom cylinder is the urethra or the urinary channel. I like to use the example of hydraulics because men really understand that. Imagine that you've got a battery-powered hydraulic system. You've got two hydraulic cylinders in the penis that fill and empty blood based upon signaling, which comes from the battery. When the battery turns on, the hydraulic cylinders open, the fluid builds up into these hydraulic cylinders, and then it completely gets closed and trapped off. That's how you maintain erections. And things that are at play, the battery, are the nervous stimulation, the hormones, and then the inflow system is your artery to the penis or arteries to the penis, and the outflow system are the veins. So a few things have to happen and go right. One, the battery and the nerves and the hormones have to work. Number one. Number two, the inflow, the arteries have to be normal in function, have to dilate in order to fill these cylinders. And then finally, these veins that are supposed to close at the end of an erection are supposed to do that normally. So when erectile dysfunction happens, you've got 1, 2, or 3 issues. Issue number one can be damage to the battery or the nerves of the penis. Issue number two can be the arteries are not working. They're not dilating. That can happen due to reasons like plaque buildup in the arteries, etc. Or number three, the veins are not closing. The veins are not able to trap the blood. You can have 1, 2, or all 3 of the problems happen, which can result in erectile dysfunction. So you can understand why ED happens to almost everyone. It turns out the penile arteries are smaller than your heart arteries, about half the size of your heart arteries. So it's not surprising that those arteries go before the heart gives up. So those arteries are prone to getting plaque buildup and therefore dysfunction, and that's why I think ED is inevitable in most men. But the bottom line is, if you've got the will, there is a way, and there's certainly a solution for you. This gets us to the 5 FDA-approved treatments for erectile dysfunction. Almost everyone that I've taken care of will start with the pills, okay? And we'll talk about the different pills that we have and some of the new agents that are out there that you're seeing online. But this is often the first place to start. Beyond the pills, there are 4 FDA-approved treatments. And I'm going to put this out front here. There are 2 treatments that I love, and there are 2 that I don't love because they don't work very well as solo therapies. And the 2 that I don't recommend highly as solo therapies are a vacuum erection device and a insertable medicine in the urethra called Muse or urethral suppository. Those 2 just do not work as solo therapies, although we will review them shortly here. The 2 that I do love are penile injections and penile implants. All right, so moving on. Let's start with oral medications. Most men do want to start with these. But I do want you to realize that approximately 40% of patients will find them to be ineffective, and nearly half the patients will stop these medications within the first year because either the medications are not reliable, they're failing, they're not reliable, they're causing side effects. That's a really, really big one. And there are concerns for long-term safety. And then there's the cost element to it. Nowadays, cost is less of a factor for most patients because the 2 out of the 4 common erectile dysfunction medicines are generic. So that makes cost a little bit more affordable and better. But that certainly remains a factor for many men. Those 4 medicines are Viagra, Cialis, Levitra, and Stendra. These are the brand names, and alongside you can see the generic names for each of these medicines. Most of my patients that have this problem, that have erectile dysfunction, will have tried sildenafil and tadalafil, and there are different reasons to try one or both of these medicines. Regardless of the medicine you do take, there are some potential side effects such as headaches, facial flushing, upset stomach, back or leg cramps, nasal congestion. Some of the other downsides to the medicines are the fact that, yes, they're not automatic. It's going to take a little bit of time for them to work, some more than the others. Some have to be taken at least a half an hour before, and others have to be taken nearly 2 hours prior to intimacy. So that can be a little bit challenging if you're really trying to time these medicines. But once again, about 40% of the cases, pills are less effective. And this is particularly true for my patients that have diabetes. If you go one step further, a lot of men are getting bombarded with commercials from places like Rougiette or Hims or Blue Chew. Now they're saying 2 is better than 1. Then they're saying 3 is better than 1. And now they're saying 4 in 1 is better than just the 1. It seems a little bit too excessive. And I will say it's probably too good to be true. But in some cases, I will certainly offer some of those options where we combine a couple of pills or 3 pills in order to optimize function. But I'd highly recommend you talk to a urologist if you're interested in any of those options. So let's move on. Let's assume that we have failed the pills and we're looking at options beyond the pills. As I mentioned, injections are a good treatment. Much like the oral pills, what injections do is that they dilate the arteries to the penis. Okay, and this is often the next step for a lot of men after failure of pills. It's a small needle placed on the side of the penis with this medication that delivers a vasodilator or dilation of arteries right to the source, which is the penile arteries. That causes the arteries to get dilated and get your hydraulic system to work. There are some risks associated with this treatment. Once again, this treatment particularly also has a very high failure rate, nearly 50% once more. One of the main risks of this particular treatment is the risk of priapism, which is an erection that lasts for more than 4 hours. This can happen at a relatively high rate, depending on who's managing these medicines and making sure that you're being dosed correctly. Apart from that, there are some other downsides. One is that some guys will have a little bit more bruising in the penis. Some guys will have persistent pain in the penis after the injection and even after intercourse. Cost is a really big factor for injections. Unlike pills and some of the other treatments, injections are not covered by insurance and often come from compounded pharmacies that manufacture these injections, commonly known as trimix. So the cost can be as much as $150 or more per a 30 to 40 day supply. These medicines also have to be refrigerated, so they can't live on a shelf. They expire, become less effective, and more importantly, they affect spontaneity of intimacy. It means you have to plan the shot. You have to say, hey, honey, I'm going to step away and give myself a shot and come back. You have to take these shots with you when you travel. You got to take a cooler with you when you're going through TSA, and God forbid you're waiting in 4 hours in line, which is what the situation is these days. So there are a lot of downsides to shots, and that's why there's a high dropout rate with injections. I've gone over some of these things already, but one of the other important ones that I like to mention here are that some men are prone to getting a condition called Peyronie's disease, which is a scar tissue in the penis which results in deformities, curvatures, etc. That can happen with penile injections as well. So this is one of the reasons to mention that. And patients that have that problem and ED should really not be looking at injections as a good long-term therapy for them. Then there's the vacuum device. I think this is a good device to rehab the penis. It's used in patients that are post-prostatectomy. It's used to maintain length and girth for a lot of men, but it is not a good therapy to use for sexual activity. It is cumbersome. It takes away spontaneity. It causes pain and numbness to the penis. It prevents normal ejaculation and normal intercourse. So I just don't find that to be a very effective solo therapy. Then there's insertable medications or MUSE. I've been in practice for over 6 years now. I have yet to prescribe this therapy to anybody. And this is really there for historical mention and historical purposes. It's just not a treatment that's common or even prescribed these days for any men. It's costly. It causes pain in the penis. It can cause bleeding and burning in the urethra. So I just do not find this to be a good solution for anybody. But it is worth a mention. It's part of it is FDA approved. Finally, the penile implant. This is the fifth, perhaps the most definitive and permanent solution for erectile dysfunction. It's important to mention some men will go through the motions. They will go through pills. They will go through injections until they decide they want a penile implant. Some men will move to the implant right away. And for those patients, it's usually after failure of pills. To each his own. Our guidelines are very strong in recommendation that patients should be presented all options up front and allowed to choose their right therapy. So a penile implant, as I mentioned, is what I call the one and done solution. It is a long-term solution for ED. Penile implants, at 10 years, about more than 75% of devices are still functional, which is a really important metric to keep in mind. I tell guys, if you're looking for spontaneity, reliability, and the hardness that you can't remember anymore, the penile implant is your best solution. It's spontaneous in the sense that you can wake up in the morning, inflate the device within seconds, and tell your partner, "Hey, honey, I'm ready to go." It brings back that spontaneity, that reliability. The other part of the implant that many patients don't realize is how discreet an implant is. In other words, there's no external evidence you have an implant. As you can see in that picture, it looks like there's this thing inside and people can see it. Well, that's not true at all. It is completely discreet. If you didn't share that you have an implant with your partner, they may not realize that at all. You look and feel exactly the same as you have before an implant. You look the same in the flaccid state. You look the same in the erect state. It doesn't change your ability to feel everything, to have the sensation, the arousal, the ability to climax, ejaculate, or have an impact on your urination. So you feel exactly the same as before an implant. And we'll walk you through a little bit more about what an implant looks like and how it works. I think I should just be able to click on this. Let's take a look. CJ, can you confirm this is working?
Yep, it is working, so I can see the movie.
I'm going to stay quiet and explain at the end. I'm going to pull it back just a little bit here so I can explain the anatomy. So this surgery is done through a small opening in the skin, either above the penis, that's about this wide, or below the penis. We call that a penoscrotal, infrapubic or penoscrotal incision. Just one small opening to put in three different components. The first component is the first components are the cylinders, two cylinders that are customized to your length and your size. That measurement is performed live at the time of surgery. The second component is a small reservoir or fluid tank. As you can see in the next to the bladder there's a small little reservoir tank. The third component is a small pump in the scrotum. All this put in through a tiny opening in the skin. Now the erections are controlled by salt water or saline, not blood. And that's where those components come into play, where saline is transferred from the reservoir tank via the pump into the cylinders and then back into the reservoir when the man is done with sexual activity. Once again, this is an ability to get a hard erection no matter what. It doesn't change your ability to climax, feel everything, sensation, ejaculation, etc. Okay. And I'm going to move on to the next slide now. High satisfaction rates. When the patients are counseled correctly, when they understand what they can expect from an implant, the satisfaction rate is 98% with a 96% partner satisfaction rate. As you can see, the Titan implant, which is made by Coloplast, is made of a material called Bioflex, which makes it to be a very resilient and strong material in comparison to silicone. It has a lot of rigidity, a lot of girth, and a lot of durability, which in turn results in higher satisfaction. Along with what we've been looking at called inflatable implants, there are also malleable penile implants, and there are advantages to them, and for the right patient, that's the right solution compared to an inflatable implant. I would say that 98 to 99% of patients will go for the inflatable implant in comparison to the malleable, but it does remain a good option for certain patients. There are risks with any surgery, including an implant surgery. Those risks include bleeding, infection, device malfunction, and other complications that may be specific to a penile implant. And certainly this is something that you and I would go over in detail together during a one-on-one conversation. Here's a very important slide. Some of the therapies that we've talked about are not covered by insurance, and it's important to mention that for the most part, implants are covered by insurance. Particularly Medicare covers penile implants, and therefore many commercial insurances also cover penile implants. Having said that, we'd certainly check with your insurance and make sure that it's part of your plan and those kind of things. And if not, then what do self-pay options and other options look like? Here's an important sort of bird's eye view of cost. You can see that injections really add up over time. So I don't see that as a good long-term solution. Whereas a penile implant sort of wins out when it comes to cost over the period of years. And as you've already learned, implants do last for a significant amount of time. And I'll tell my patients usually 10 to 15 years is what you generally expect. Yes, they can fail sooner, but they can also last longer than 15 years. I'll pause there for the moment. CJ, give me 1 second. I'm going to pause my audio, but I want to introduce Tim here. And if you guys can help him get on, I will be right back.
Absolutely. Tim, are you there?
Well, 1 second here.
All right, we can hear you.
Yes, I'm here.
That's great. Fantastic. Yeah, everybody. So this is Tim. He is an actual patient, and he's here to have a chat with Dr. Kapadia and give you the patient's perspective of the procedure. Tim, why don't you maybe introduce yourself for a sec and let us know how you ended up getting the procedure and give us a little bit of background there. And what I will say is while Tim is speaking, please feel free to use the chat button. It's probably at the bottom of your screen. It is an anonymous question that you'll be sending to us. If you want something directed specifically to either Dr. Kapadia or Tim, please feel free to mention their name. And I'll go ahead once Tim's introduced himself and I will start getting to your questions.
CJ, did you also talk about the QR code and all that?
Yes. Okay. Good point. Yeah. So thank you. So on your screen, you will see there is a QR code that takes you directly to Dr. Kapadia's online scheduling. So get your phone out, go ahead and scan that QR code, and you'll be taken to that second screen where you can enter your reason for visit. If you enter webinar, you will get access to priority spots that have been set aside for the attendees of this webinar, meaning you'll get to see Dr. Kapadia sooner than otherwise would be possible. So we've opened up a bunch of slots for you all, And so go ahead and scan that, put in webinar, and that will get you access to those slots. So Tim, why don't you go ahead and tell us a little bit about your story?
Can you hear me?
We
Sure
can hear
can.
you, Tim.
Okay.
If
What do
I
you
may,
just want me
Tim,
to
will
tell
you
you?
kind of go over how old you are and just a little bit about yourself?
I am 68 years old, and my journey with ED started probably about 6 years ago. Um, I did start with medication or the Viagra Cialis
Yeah.
avenue, and went through that, and
How long did that work for you?
probably about I'll say about a year and a half. It
Okay.
could have worked more, but it was just the side effects that was just I just did not like it.
Yeah. What were those side effects that you were experiencing on a daily basis?
Major headaches. It was hard to swallow at times. My eyes would burn
Yeah.
severely.
Yeah. Yeah. So you
So
did
that was
year and
that
a half.
was
Is there
very
anything else about
frustrating.
your health that would have potentially put you at risk for ED?
Beg your pardon?
Is there anything about your history, your medical problems that would have put you at risk for ED, such as
High
diabetes?
blood pressure
Okay.
and pre-diabetes.
Gotcha. Yeah. And so then did you move on to doing shots?
Yes. Then I went to the Trimax,
Hmm.
and for me, I always hated needles.
Yeah. Yeah.
But you don't have, you just look for different choices, and when you
Yeah.
want to maintain a good sexual relationship with your partner. So I went that route, and
Yeah.
that worked for a while. However, it started. Uh, I started having pain. Uh,
With the injections?
yes,
Yeah.
and as a matter of fact, I went through all four stages
Did you really?
of the Trimax.
Yeah. Oh, yes. So you went from trimix 1, 2, 3 to 4.
Yes, yes. And then once I got to four, it
Hmm.
at that point that's when I started having the pain,
Yeah.
and at that point it was hit and miss.
Yeah. 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 Exactly. So this started, sounds like a number of years ago now for you. You did the pills for a year and a half. How long
Hmm.
did you did the shots?
I did the shots for about 8 months.
Yeah. Yeah. So I think as most folks can tell, this is a relatively typical timeline, right? So we talk about a high dropout rate with pills, and Tim is a classic example of why that is. Within a year and a half, they may have worked better, but because of the side effects, it just was not worth it. And any guy would do anything to maintain intimacy, and it must have been bad enough where we're looking for a different treatment for you.
Yes,
When it comes to the injection, sounds like within the year you kind of the writing was on the wall. I mean, it wasn't going to be a long-term solution for you, and that's kind of exactly
that's
what we talk about. And you're a real life example of why that is.
hmm yeah. When I first started the Trimax, it worked great. I mean, something new, different. It worked, but man, it got old after a while, and
Right.
it started having issues with it.
Yeah. Right. So tell me how you came to see me, and kind of what you took away from our first meeting.
Well, of course, I was my urologist, Dr. Kreitman. He was working with me through this process, and he introduced me to your practice. That's how I got to you.
Mm-hmm. And what was your takeaway from that first conversation you and I had?
Well, the first conversation, it was hard to believe that that was even possible, to having an implant that would give you an erection when you wanted one on demand, and have the same natural effects. That was hard to believe
Yeah.
that was true, but at the same time, it was exciting. And so, of course, I talked to my wife about it, and we came in, and then you showed us how it all worked, and with the model and everything, and we decided to take that step to do that.
Gotcha. Yeah, I mean, I think a lot of folks are going to be, fearful of a surgery that is purely elective, and I absolutely understand it. I see that every day, and for some folks, this is not an option, and I totally respect that, and I totally acknowledge that, and understand that. For some folks, it's a viable option.
Mm-hmm.
And it's not because they want intimacy more than other guys. It's just that from a mindset standpoint, they're more willing to consider an operation. And so I think you kind of made that decision. And this is where I kind of promised the good, bad, and the ugly. So walk us through first how it was, leading up to surgery and your first week of surgery. How did that go?
You seen my first week of surgery or after the surgery?
Leading up to surgery and how the first week went after surgery.
Well, leading up to the surgery, you just didn't know what to expect. But after, be honest with you, Dr. Kapadia, your presentation, how you presented it to us, made it more comfortable for me to take the step to even have that leading up to
Sure.
the surgery.
Yeah, yeah. How'd you do the first week though? Were you
Well, after the first week, it was hit and miss, because learning how to operate the pump, knowing where that button was, and
yeah,
as it was kind of funny, because I didn't know how to deflate it.
yeah. And
I had to come in and he showed me how to do that.
How long did you struggle with the process of really learning the device?
2 weeks.
2 weeks. And I imagine that those 2 weeks are after the first 3 weeks or so from your surgery. So around the 5 or 6 week mark of your surgery, would you say?
After 5 weeks, it was great. I mean, once you really get the hang of it,
yeah,
it's
and when did you
I
feel,
don't beg pardon?
Tim, when did you feel that the soreness went away? Everything was just back to just
Probably about 6 weeks.
okay. Yeah. And I will say that Tim could be a little bit ahead of the curve. Some men are ready at 6 weeks. Some men don't feel like they're at the peak performance level close to 2 to 3 months. And that's part of what an implant journey is. Are there things that you would, well, you tell me, I know that your decision you think was a good decision. Are there things that could be blinders for some men that they didn't think about after the surgery?
Let's see. It's hard for me to even go back now, Dr. Kapadia, because I've had my implant for so long, over a couple of years now.
Yeah.
And I'm trying to
Can't remember the time before that, huh?
yeah, it's just only thing that comes to my mind was really learning how to inflate and deflate. There was a trick to that.
Yeah.
And then once I learned that, and then past the soreness,
mm-hmm.
It was, for me, was the greatest decision that I could have made.
Yeah. Well, that's wonderful to hear. I'll pause here. Tim, if there's anything else you want to share? Otherwise, we'll open it up to questions from the audience, because I'm sure that they're dying to ask questions more to you probably than me.
Well, I think what made this a good decision for me was going to your practice, being that you've done this and you have experience in doing it. That was a key in having this procedure as well. Going to someone who knows how to do this and do this all the time, rather than just a hit and miss someone who doesn't do this kind of procedure, but going to someone who actually knows how to do it and do it frequently has been great.
Yeah. Yeah. Well, that's good to hear. And I think that at Georgia Urology, we really sort of pride ourselves on making sure that our patients are seeing some of the best and high volume surgeons for their particular needs.
And could I say something, Dr. Kapadia?
Yes, sir.
Um, I visited my brother-in-law. He's, as a matter
Mhm.
of fact, he's 3 years older than me,
Yeah, yeah.
and I began to share with him,
Hmm.
and he said, "That's unbelievable. There's no way that can happen."
Yeah.
And I shared it with him, and he came to visit your office,
Yeah.
and till this day, he's excited about making that decision. He's doing well with his as well.
Yeah, well, that's awesome. I know that story as well as you know. So that's fantastic to hear. You know that you've been an advocate for this, and there's some real life examples of how men talk to other men and come to these kinds of decisions. So I appreciate you coming on and sharing your story with us. But let's take a few questions from the audience.
Great. So, what I'll do, Dr. Kapadia, if you agree, is I'll send one your way and one Tim's way because we have a whole bunch. So,
Perfect. Perfect. Go for
all
it.
right. So we have one question, interesting question. So, what does a patient do from out of state, and how does the process change, or do the risks? Are there any additional risks of coming in from out of state to have the surgery?
Yeah, and it's a good question. There shouldn't be, so it depends on your insurance plans and whatnot. If you have certain state-based plans, and that could be an impact. But generally speaking, though, I do see a lot of patients from out of state. And I think patients that are really sort of those guys that have done their research, if you will, um, are really keen on going to surgeons that are center of excellence surgeons. Um, by no means does that guarantee a better outcome or sort of prevent any you know bad outcomes. But in general, we know that surgeons, especially in the prosthesis world, whether it's hip, knee, and now the penile implant, especially in the prosthesis world, high volume implant surgeons can navigate difficult waters, if you will, better than surgeons that do one, two, or five a year. What makes a center of excellence is usually, um, as um, as CJ mentioned, doing a high volume of these implants. And depends on which brand it is that you talk to, but at least 25 to 30 implants a year with also good outcomes. And those are things that are not that are objective. They're not subjective. That a status can't be bought. Could it be used as a marketing tool? Sure, but it is not a status that can be bought. You have to demonstrate high volume and good outcomes. And these are sort of it's up to the company that plans these, but it is maintained by the company. And these are meant to be honest and transparent results for the patients.
Fantastic. So Tim, quick question about your partner. What was your experience as far as when you made your decision? How did your partner, your wife, feel about you getting it? And then ultimately, what are her thoughts on the post implantation life? Sort of give us her thoughts on everything.
Sure. Um, I'll be honest. Our intimacy is so much better than when before I even needed an implant. Because there's no, um, premature ejaculation. You're more. She loves it. Be honest with you, and it has brought us that part of our lives. That part of our life has been great. It's brought us closer together.
That's wonderful to hear.
That's
Tim, if I can piggyback on that, I think what guys and couples realize as when ED starts to happen and you're having to pop pills or do shots, the times of intimacy goes down from, say, 2 or 3 times a week to maybe once a week to maybe once every 2 weeks, maybe once every month. So the frequency of intimacy really goes down as you're going through that journey of pills to shots and so on and so forth. But once you introduce that implant, when you've got the sure thing, that frequency starts to pick back up again, which is, I think,
Hmm.
pretty incredible.
That's correct.
There for the next
Yes.
question.
Well, yeah, and to that point, we do have a question about whether it's 100% guarantee that you are going to be able to have intercourse once you have the implant.
And I think in generalities, that's a tough question to answer, right? Nobody can guarantee you 100% success. If they're saying that, then run away from that place. It's not a guaranteed in any form of way. There are many nuances to being sexually active that goes beyond just the hydraulics and being able to get an erection. And I think that question is probably addressed a little bit more specifically on in a one-on-one setting to really understand what the nature of the question is. But if an implant is working well, I can't imagine why that should prevent men from having nearly 100% satisfaction.
Fantastic. So Tim, when
Yes.
you're pumping up the implant, does it interfere with the mood, or have you sort of worked it into a I guess a process? I think a lot of people are concerned that the actual action of doing that might sort of dampen the mood.
No, no, not at all. Because all that to me, I mix it with the foreplay. Be honest with you,
Mhm.
and it doesn't interfere with that at all. It's not something that you are someone is noticing that you're even doing that. You can do it discreetly, right? You're right there. And the only way my wife would know it if she could, if the music is not on, she could hear it.
There you go. I love that
Yeah.
answer. I tell couples all the time, make it part of foreplay.
Yeah.
And and to those that are getting an implant, they're so used to the whole sequence of pop a pill and do the shot and all that that nothing compares to the spontaneity of an implant. Now, having said that, it's let's be honest. This is nothing like the erections of your 30s, right? I mean, that was a different time and a different place. But this gets pretty darn close, and that
Hmm.
And so maybe a two-part question here. So, can you speak to the different sizes of implants, and whether that affects the length or girth of the penis? And then also just the tactile, can you feel it? Can you feel the pump? Is there anything that would suggest that you have an implant?
yeah. So good question. It's not a one size fits all sort of a process. Implants come in different sizes, and I have to ultimately determine your size at the time of surgery from one tip to the other with live measurements and the penis on the full stretch. Okay, so the goal is to get you the biggest implant possible without making it too big where it can result in complications. So everyone's size is different, and implants do come in different sizes because of that reason, including the inflatable component of the implant that it comes in different sizes. For example, with Coloplast, it goes from 16, 18, 20, 22, 24, 26, 28, etc. So we customize that at the time of surgery. With the question regarding can you feel things, what's the tactile feedback, etc. When it comes to the cylinders, well, they are going to mimic your natural cylinder. So when you're in the erect state, you can't tell the difference. Your partner can't tell the difference. It feels like a normal erect penis. You can't feel the reservoir, so that's out of the question. The only thing that you can feel, if you really felt for it, would be the pump. And that's also going to require actually finding the pump to feel for it. So, there isn't, anything obvious about it. Yeah, if you get to learn the implant over time, you'll know some small nuances and small things about the implant that'll, make it obvious to you, yeah, there's an implant in there. But to the inexperienced eye, it's not a visible thing, if you're in the shower, in the locker room or something like that. Tim, if you want to speak on that in terms of, the feeling of the pump or whatnot.
Um, Not for me, not unless I really, I'm trying to get an erection, I can feel the pump. Other than that, it's normal. You
It's just
don't,
there,
yeah.
part of the body.
Yep.
And you know what? I'll follow up with this question to you, Dr. Kapadia, because it sort of dovetails. Are there any conditions that prohibit the implant? Someone was concerned about a vasectomy. And then secondly, well, let's start with that.
I mean, the short answer is honestly no. I don't think that I've encountered a patient that I've turned away due to surgical history or anything of that nature. Yes, having said that, there are some really bad medical problems that might prevent you from going under general anesthesia or coming off certain medicines like blood thinners that could potentially prevent us from offering that surgery. But I think the short answer is no.
Fantastic. And just to clarify, this pump is there's no change in the testicles or in the scrotal sac. This just goes in there as a
That's
essentially
correct.
a third item in there.
That's correct. You've got two compartments in the scrotum and a sort of a septum or wall in between the two compartments. And in each of the compartments, there's each one testicle. This pump goes in between, right in that septal wall, in the wall, where it's got its own little space separate from the other two compartments. So they don't ever violate the compartments of the testicles.
Fantastic. And so a question about Peyronie's. Does this help with Peyronie's? Do you ever do an implant with patients who have Peyronie's, which is the curvature of the
100%.
penis?
100%. This is a big population of my patients where they've got Peyronie's disease and they've got erectile dysfunction that is not responsive to pills. And as you've heard previously, shots are not a good option if you've got ED and Peyronie's. Peyronie's can get worse with the shots. So therefore, a big patient population of mine is guys that are needing an implant for both ED and Peyronie's. And yes, Peyronie's is fixable and treatable with an implant.
Fantastic. And so, Tim, from a pain perspective, what did you experience shortly after surgery? Was it over-the-counter pain meds? Did you need anything stronger? And how long did it last?
Mine's a relatively short, couple of weeks. By the third or fourth week, my only issue was learning how to uh, inflate and deflate. And once I learned that, I didn't have any complication with pain.
Got it. Um, so, Dr. Kapadia, two-part question here. Do you need to take any hormones with the implant? I'm assuming we're talking about libido and so forth. And separately but related, what about if a patient has arousal issues or libido issues separately?
Really great question. And this kind of goes to how sexual dysfunction isn't just one problem, right? It's not just the hydraulics are failing. There's a lot more to it. An implant is a replacement of the hydraulics. It is not a replacement of, the ability or inability to climax, feel everything, have normal sensation, libido, etc. There are far more other complex reasons why men can have that, and sometimes untreatable reasons why men can have that. But this is simple, plain and simple hydraulics replacement. It allows you to be sexually active. It cannot, if you couldn't climax before an implant, it cannot change that, or it won't guarantee that it would be fixed, right? If you had libido issues prior to an implant, well, that sometimes could be related to the difficulty getting erections and lack of confidence. That changes. However, if there are true libido issues outside of the erections, then the implant won't address that. It's not a fix all. It's a fix for the hydraulics is what it is. So if you need testosterone for other reasons or other treatments for arousal, and there are some out there, and we could talk about that separately, then that would be a different focus apart from the implant.
Fantastic. And so, Tim, we sort of touched on this, but can your wife tell that you have an implant? Did it at any point did it, was it unusual or strange? And just sort of I think a patient wants some reassurance on that.
No, absolutely not. It's just like everything's natural.
Fantastic.
So simple. I love that.
Yeah. So and I guess this is a good question about especially now these days with TSA. But going through TSA, any issues like other implants, knees
Yeah.
or shoulders or anything like that?
Yeah, I get that a lot now. Back in the day, these implants would not, make any noise, when you're going through just the X-ray. But now they've got those big scanners or whatnot, right? So that's changed a little bit. But what's also happened is this recognition amongst the TSA folks that this gentleman has an implant, and it's a very short, quick conversation. Yes, that can happen. They might get an alert saying, "Hey, do you have this?" And all you got to say is yes. But I'm telling you, it's a lot better than having to take refrigerated medicine in a cooler through TSA.
Yes.
And then I'm not sure how you want to address this, Dr. Kapadia, but payment questions, cash pay for someone who does not have insurance or who was denied by their insurance
Yeah,
carrier.
good question. I will leave it off the webinar as a direct answer because one, I'm not the finance guy. But two, I think that you have to sort of, if you're a Georgia urology patient here, we can certainly walk you through that. If you're out of state or whatnot, I think we can probably walk you through that as well when we do get to the point of discussion, with the financial team or whatnot. I can tell you that the rates that we have here are very comparable and better than probably hospital rates. So that's a little bit of a specific conversation that I'm happy to have. I can sort of talk about the ballparks. The implant material and the prosthetic device actually has a material cost. Then you have to account for surgeon fee, facility fee, anesthesia fee. Those are the other components. I think that gets you in the ballpark of anywhere from $18,000 to $20,000, generally speaking. But I think it has to be very specific to the patient. So I don't want to get into the specifics of that.
Fantastic. So I guess another good question is and Tim, maybe you can answer this first part, and then Dr. Kapadia the second part. Um, the first question is, does your erection feel as firm as you want it to, as firm as it was before you started having your erectile function concerns? Um, is there anything that feels unnatural about the strength of the erection?
Uh, I would say from 10% to 100%. I'm probably right at 97.
So pretty much all the way there. That's awesome.
It's a big number. I love that.
And then Dr. Kapadia, can you over inflate it?
No, no. Your penis has a certain capacity beyond which you cannot inflate more because the pump gets so hard that your fingers could fall off. You're going to inflate until you can't press anymore. And that's where the pressure equilibrates between the penis and the pump. And that's where you wouldn't be able to inflate anymore. So, no, you can't break it. You can't, it's not like if you keep pumping like a catheter balloon or a tire tube that you just, pop off, it wouldn't happen.
Gotcha. And any contraindications with blood thinners?
Well, generally speaking, no. Sometimes I will operate on guys that need to stay on aspirin. With things like Eliquis or Xarelto and so on and so forth, there are ways to come off those safely as long as your doctor feels that it is okay for you to come off them. In very rare cases, I will offer to do a surgery on somebody that's on Xarelto, but that would be extremely rare. And generally speaking, it risks some complications, including bleeding, that would potentially complicate your recovery. But it would be pretty rare for us to not find an opportunity to have guys come off the blood thinners and then restart within a couple of days of surgery.
Got it. And is this? I know you mentioned time frames. Is this supposed to be permanent? Meaning, can it be reversed? And then what happens, for example, if at 15 years the pump fails or the device fails?
Right. Yeah, we haven't heard that question yet. So, but the idea here is that there is no going back after you get an implant. You cannot go back and say, "I'm going to get this removed and start using pills or shots." Right? That's not going to happen. The implant takes up space that used to be these erectile bodies. It squeezes that tissue out over time, and that tissue sort of atrophies or shrinks and is replaced by the implant cylinder. So you can't go back. To that point, though, if the device fails in, say, 5 years or 10 years or 15 years or 20 years, most of my patients are right back in the office to get a replacement because they've been so happy with the implant. So it can be replaced at a later time in your life if it does fail. And
Great.
on the flip side, if the device has failed and you're no longer using it, it does not need to be removed.
And then I guess we're hitting up on time now, but a couple last questions. So um, the your backlog and timing for getting the procedure, how's your schedule looking these days?
Provided with the webinar links, we can get you into the office. I would probably anticipate close to six weeks or so, here and there. Could be a little bit longer, could be a little bit sooner. We usually keep a short list of patients that are on the cancellation list because cancellations happen because of the elective nature of surgery, and we try to get patients in as soon as we possibly can.
And a pretty specific question here, but one that may help patients make their decision. So we have a patient who is considering coming from out of town and just hasn't gotten the answers on number of procedures performed, infection rates, patient satisfaction from their local doctor. What are the questions you would ask? What are the considerations you would make when choosing your doc?
I think a doctor should easily be able to tell you, how many implants do you do on a year-to-year basis, or have you done in the last 3 months, or have you done in the last year? I think it's fair to ask that question. If you feel confident in your urologist, then by all means use them. They're a good local resource, and I'm never going to be in the business of not talking up other urologists. They could have great experience in doing implants, but if you're not getting those clear answers, then you have to ask the right questions, which you are. I think that it's a very simple question that a urologist should be able to answer. How many have you done of these have you done in the last 3 months or the last year? Sometimes it's hard for us to answer how many we've done in our whole career, but a good time frame is 3 months or a year. I think that should give you some sense of what that number looks like. If it's less than 5 in the last year, then they're not doing enough implants. Doesn't mean they can't get you a great outcome. If you have confidence, then certainly feel free to move forward with your surgeon. But I would say probably at least 5 in the last year is a good number to keep in mind.
Great. And Tim, last question for you.
Mhm.
So you mentioned that there is a little noise that comes from the pump.
Yeah.
You use music to cover that.
Mhm.
How noticeable, obviously this is very subjective, but how noticeable is that noise, especially for someone who's concerned about a new partner who may not know that they have a implant?
It's not that loud. I mean, music is gonna if you got music playing and you're into each other, you're not gonna hear it. It's not that loud at all. It has to be absolutely quiet, really quiet for you to hear that noise. But
Got it.
if there's music playing, you're not gonna hear it at all.
All right. Awesome.
And
And
to that point, I'll just say this: transparency is always great because partners can be very supportive. But number two, if you really had to be discreet, I have plenty of patients that just sort of step into the bathroom and come back, and voila, they have
Mhm.
an erection. So
Yeah.
you can certainly have some a good level of discretion with an implant.
Dr. Kapadia, if you don't mind sharing your volume real quick, just the number that you've done
So
recently.
yeah, so once again, we get to those numbers, right? So I probably do 2 a week. So on average, about anywhere from 6 to 10 implants a month. And if you kind of do the math there, probably close to 25 in 3 months or so, and so on and so forth. I think you guys can do the math that way. I would probably guess anywhere from 60 to 100 implants a year.
Fantastic. So I think with that, we've answered most of our questions. And of course, if you have any others or things that are very specific to you, that would be best answered in a consultation with Dr. Kapadia. So as we mentioned before, please go ahead and scan that code, type in webinar, and you will be able to get an appointment with Dr. Kapadia as soon as possible.
All right. Thank you so much to everyone that joined today. I appreciate your presence here. Thank you to CJ, and a huge thank you to Tim for being on the call and answering these questions very candidly. I know that patients really appreciated this personal insight. And once again, thank you to Coloplast for allowing us to partner and do this presentation. Thanks, everybody. Have a great evening.
Thank
Thank
you.
you.